You know, there's this image we all carry around in our heads about what a heart attack looks like. Someone clutches their chest, they grimace in pain, maybe they stagger, grab onto something for support. It's dramatic, it's unmistakable, it's the kind of thing you see in movies, on television shows, in those public health posters. And I'm not going to tell you that doesn't happen, because it does. I've seen it happen many times over 30 years of practice. But here's what I've also seen, and this is the part that troubles me, the part that keeps me up sometimes when I think about patients I've known over the decades. I've seen heart attacks that looked nothing like that. Heart attacks that presented as tiredness, as indigestion, as a vague sense that something wasn't quite right, nothing more specific than that. I've seen patients who had heart attacks and didn't know it until we found the evidence on an EKG weeks or months later. Scar tissue on the heart muscle, damage that had already healed, a cardiac event that came and went without anyone realizing what it was. And what strikes me most is how often these patients told someone about their symptoms. They mentioned feeling unusually tired. They complained about what they thought was acid reflux. They said their jaw felt strange or their back hurt in an unfamiliar way. And they were told sometimes by doctors, sometimes by family, sometimes by themselves that it was nothing. Stress, aging, a pulled muscle, too much coffee. So, today I want to talk about that. About the heart attacks that don't announce themselves, the ones that slip past our expectations because they don't match the script we've been taught to recognize. This isn't about making you anxious. It's about helping you understand something that could genuinely matter, maybe for you, maybe for someone you love. Let me start by explaining what we actually mean when we talk about a silent heart attack. The medical term is silent myocardial infarction, and it refers to a heart attack that occurs with minimal symptoms, atypical symptoms, or sometimes no noticeable symptoms at all. The heart muscle is damaged, blood flow was blocked, oxygen was cut off, cells died, but the person experiencing it didn't recognize it as a cardiac event. Now, that might sound impossible. How can something so serious go unnoticed? But it happens more often than most people realize. Studies suggest that somewhere between 20 and 50% of all heart attacks may be silent or unrecognized at the time they occur. The numbers vary depending on the population studied, but the consistency of the finding is striking. We're not talking about rare exceptions. We're talking about a substantial portion of all cardiac events, and here's where age comes in. As people get older, and I'm talking specifically about adults over 60, though this can start earlier, the likelihood of having atypical or silent symptoms increases significantly. The classic crushing chest pain becomes less reliable as a warning sign. Other symptoms take its place, but they're often misinterpreted. Why does this happen? There are several reasons, and they're worth understanding. The first has to do with changes in the nervous system. Pain perception isn't static throughout life. The nerves that carry pain signals can become less sensitive with age. This happens gradually, and it varies from person to person, but it's a real phenomenon. The alarm system that would normally scream, "Something is wrong with your heart," may only whisper instead. Diabetes accelerates this process considerably. Diabetic neuropathy nerve damage caused by years of elevated blood sugar can blunt pain signals throughout the body, including those coming from the heart. I've cared for diabetic patients who had significant heart attacks with almost no chest discomfort whatsoever. They felt tired, maybe slightly nauseated, but there was no pain that would have sent them rushing to an emergency room. The second reason involves the nature of coronary artery disease itself. In older adults, the blockages in heart arteries often develop slowly over many years. The heart has time to develop some collateral circulation, small alternative blood vessels that partially compensate for the blocked ones. This doesn't prevent heart attacks, but it can sometimes make them less acutely dramatic. The event still damages the heart, but the immediate symptoms may be muted. The third reason, and this one is particularly important for women, is that heart disease can present differently based on biological factors we're still working to fully understand. For decades, most cardiac research was done on men. The symptoms we learned to recognize the textbook symptoms were largely derived from male patients. Women's symptoms were treated as variations, as exceptions, when in fact they may be equally common and equally significant. Let me tell you about a patient I'll call Dorothy. She was 73 years old, a retired librarian, widowed, living independently. She came to see me because she'd been feeling unusually tired for about 2 weeks. Not sleepy exactly, but drained. She said she used to walk to the grocery store 3 blocks away without any trouble, but lately she'd been taking the car because walking felt like too much effort. She also mentioned some discomfort in her upper back, between her shoulder blades. She'd assumed she'd slept in an odd position, maybe pulled something while gardening. It wasn't severe pain, just a persistent aching that wouldn't quite go away. Her primary care doctor had seen her the week before and done some basic blood work. Everything looked normal. She was told to rest, take some ibuprofen, maybe see a physical therapist if the back pain continued. But something about her story bothered me. The fatigue was new. The back discomfort was new. And when I asked more carefully, she mentioned that she'd also been having what she called indigestion, a heavy feeling in her stomach, occasional nausea, especially when she exerted herself. I ordered an EKG. It showed changes consistent with a recent heart attack, not massive, but definite. When we did further testing, we found that one of her coronary arteries had a significant blockage. Dorothy had experienced a heart attack, not a dramatic one, not the kind you see in movies, but real damage to her heart muscle. And she had told multiple people about her symptoms. No one connected the dots until we looked at them together as a pattern. This brings me to the 5 subtle signs I want to discuss today. I'm not going to present these as a checklist because that's not how the body works. Symptoms don't arrive with labels attached. They blend together, they fluctuate, they get mixed up with the ordinary discomforts of daily life. But there are patterns worth recognizing. And if you understand these patterns, you'll be better equipped to notice when something might deserve attention. The first pattern is unusual, persistent fatigue. I'm not talking about being tired after a long day or sleeping poorly one night. I'm talking about a fatigue that seems out of proportion to what you've been doing. A fatigue that doesn't improve with rest, a sense of being drained that persists for days or weeks. Many of my patients describe it as feeling like they're walking through mud or wearing a heavy coat they can't take off. Simple activities that used to be easy suddenly require effort. Climbing stairs feels harder than it should. Taking a shower leaves you needing to sit down. This kind of fatigue can be caused by many things, of course. Anemia, thyroid problems, depression, poor sleep. I'm not saying it's always cardiac, but when it's new, when it's persistent, and especially when it's accompanied by other subtle symptoms, it deserves attention. The heart is a pump. When it's not pumping effectively, when part of the muscle is damaged or struggling, the body doesn't get the oxygen and blood flow it needs. Fatigue is often the first sign that something in that system isn't working properly. I remember a patient, a man in his late 60s named Harold, who came in complaining that he couldn't keep up with his grandsons anymore. He'd been an active person, played golf twice a week, but over the past month he'd lost interest. He said he just didn't have the energy. His wife thought he might be depressed. When we tested him, we found evidence of a heart attack that had occurred silently sometime in the previous few weeks. His fatigue wasn't psychological. His heart had been damaged, and his body was telling him quietly, persistently, that something was wrong. The second pattern involves indigestion-like discomfort. This is one of the most commonly missed presentations, especially in women. The person feels a heaviness or pressure in the upper abdomen. They might describe it as heartburn or a sense of fullness or nausea. Sometimes there's actual vomiting. Often they reach for antacids, assuming the problem is digestive. But here's what many people don't realize. The nerves that supply the heart and the nerves that supply the upper digestive tract share common pathways. The brain can have difficulty distinguishing between signals coming from the heart and signals coming from the stomach. So when the heart is in distress, the sensation can be felt as a digestive problem. I had a patient years ago, a woman in her mid-60s named Barbara, who spent nearly an entire day treating what she thought was food poisoning. She'd had dinner at a restaurant the night before, and when she woke up feeling nauseated with a strange pressure in her stomach, she assumed she'd eaten something that disagreed with her. She took antacids, she rested, she avoided food, but the feeling didn't go away. Finally, late in the afternoon, her daughter convinced her to go to the emergency room. By then, she'd been having a heart attack for approximately 18 hours. A significant amount of heart muscle had been damaged in that time. Barbara survived, but her heart function was permanently reduced, and she told me afterward, with some bitterness, that nobody had ever told her a heart attack could feel like a bad stomach. The third pattern is shortness of breath with minimal exertion. Again, this can have many causes: lung disease, anemia, deconditioning, anxiety. But when shortness of breath is new, or when it occurs with activities that previously caused no difficulty, it's worth paying attention. The heart and lungs work together as a system. When the heart isn't pumping efficiently, blood can back up into the lungs, causing congestion that makes breathing more difficult. Some people notice this primarily when they're lying flat. They have to prop themselves up on pillows to breathe comfortably at night. Others notice it during physical activity or even during conversation. I often ask my patients to think about their baseline. What could you do comfortably 6 months ago? A year ago? If there's been a significant decline in your exercise tolerance, if you're getting winded doing things that used to be easy, that's important information. One patient, a retired school teacher named Margaret, told me she'd stopped singing in her church choir because she couldn't hold the notes anymore. She ran out of breath. She'd assumed it was just aging, just her lungs getting older. But when we investigated, we found that her heart had been weakened by a silent heart attack that had occurred sometime in the previous year. The fourth pattern involves pain or discomfort in unexpected locations. We're taught to watch for chest pain, and chest pain certainly matters. But cardiac-related discomfort can appear in the jaw, the neck, the shoulders, the upper back, even the arms, sometimes without any chest involvement at all. This is called referred pain. The nerves that supply the heart also connect to areas in the neck, jaw, shoulders, and arms. When the heart is in distress, the brain sometimes interprets the signal as coming from one of these other locations, instead of or in addition to the chest. Women seem to experience this pattern more frequently than men, though it can happen to anyone. I've seen patients who were convinced they had a dental problem because their jaw hurt. Patients who thought they'd strained a muscle in their shoulder. Patients who went to a chiropractor for upper back pain that turned out to be cardiac in origin. The key question to ask is, does this discomfort come on with exertion and improve with rest? That pattern symptoms, triggered by activity and relieved by stopping, is classic for cardiac-related pain, regardless of where in the body it's felt. One of my colleagues likes to say, the body rarely reads the textbook, and that's true. Symptoms present however they present. Our job is to recognize the patterns even when they don't look exactly like we expected. The fifth pattern is perhaps the hardest to describe, but in some ways the most important. It's a general sense that something isn't right. I've had patients tell me, I don't feel like myself. They can't point to a specific symptom. They're not in pain exactly. But there's a feeling of being unwell, of something being off, that persists over hours or days. We tend to dismiss these vague feelings, both as patients and as doctors. They're hard to measure. They're hard to explain. They don't fit neatly into diagnostic categories. But over 30 years of practice, I've learned to take them seriously. The body knows things before the mind has words for them. When someone tells me they feel like something is wrong, even if they can't articulate exactly what, I pay attention. I remember a man named George, 71 years old, who called my office one morning and said he just didn't feel right. No chest pain, no shortness of breath, no specific complaint. Just a sense of unease that had been growing since he woke up, a feeling that something was happening in his body that shouldn't be happening. I told him to come in right away. His EKG showed an evolving heart attack. We got him to the cardiac catheterization lab within the hour, and they opened the blocked artery before it caused extensive damage. George's instinct, that vague sense of wrongness, quite possibly saved his life. Now, I want to be careful here, because I don't want to create unnecessary anxiety. Not every episode of fatigue is a heart attack. Not every bout of indigestion is cardiac. Not every ache in your jaw or shoulder represents a blocked artery. If that were the case, emergency rooms would be overwhelmed with false alarms, and people would live in constant fear of their own bodies. What I'm encouraging is thoughtful awareness, understanding your own baseline, noticing when something changes in a way that seems significant. The key factors that should prompt concern include new symptoms, especially if they're persistent. If something unusual has been happening for days or weeks and isn't getting better on its own, that's worth evaluating. Symptoms that occur with exertion and improve with rest. This pattern suggests that the symptom might be related to increased demand on the heart. Multiple subtle symptoms occurring together. Fatigue alone might be nothing. Fatigue combined with indigestion and shortness of breath is more concerning, a pattern that's different from your normal. You know your body. You know what your usual aches and tiredness feel like. When something feels qualitatively different, even if you can't explain exactly how, that instinct is worth following. One thing that frustrates me about how medicine is sometimes practiced is the tendency to dismiss symptoms in older adults as just aging. Yes, aging involves changes. Yes, people in their 60s and 70s often have less energy than they did at 30. But significant, sudden, or progressive changes in function are not simply normal aging. They're symptoms, and symptoms have causes. When someone says, "I'm just getting older," to explain away a new pattern of fatigue or shortness of breath, I want to push back gently on that assumption. Getting older doesn't mean your heart is allowed to silently struggle without investigation. Getting older means we need to pay more attention, not less, to changes in how you feel. The same applies when symptoms are attributed to stress, anxiety, or emotional factors. These attributions may sometimes be correct, but they shouldn't be made without ruling out physical causes. I've seen too many patients whose heart attacks were initially dismissed as panic attacks or stress reactions. By the time the true diagnosis was made, significant damage had occurred. Let me talk specifically about women for a moment, because this is an area where medicine has historically fallen short. For decades, heart disease was framed as a men's disease. The research was conducted primarily on men. The symptoms we learned to recognize were derived from male patients. Women who presented with different symptoms, more fatigue, more nausea, more back pain, less dramatic chest pressure, were often misdiagnosed or dismissed. This has improved somewhat in recent years. There's more awareness now that women's cardiac symptoms can differ from men's. But old habits persist, both among healthcare providers and among women themselves. I've had female patients tell me they didn't want to make a fuss. They didn't want to seem like they were overreacting. They figured if it were really serious, it would hurt more. It would be more obvious. These are dangerous assumptions. Women die of heart disease at nearly the same rate as men. Their heart attacks are just as real, just as damaging, and just as worthy of urgent attention, even when the symptoms don't match the classic male presentation. What should you do if you notice some of these subtle patterns? First, don't panic. As I said, most instances of fatigue, indigestion, and vague discomfort are not heart attacks. Context matters. Patterns matter. Duration matters. But if you're experiencing symptoms that are new, persistent, or concerning, particularly if you have risk factors for heart disease like high blood pressure, diabetes, high cholesterol, a family history of cardiac problems, or a history of smoking, it's reasonable to seek evaluation. You don't need to go to the emergency room for every episode of tiredness, but you should talk to your doctor. Describe what you're experiencing. Be specific about when it started, how long it lasts, what makes it better or worse, and whether it comes with other symptoms. An EKG is a simple, painless test that can often reveal whether you've had a cardiac event. Blood tests can check for markers of heart damage. Further testing, if warranted, can assess how well your heart is functioning. The key is not to wait too long. Heart muscle, once damaged, doesn't regenerate. The sooner a heart attack is recognized and treated, the more muscle can be preserved, and the better the long-term outcome. I've seen patients who delayed for hours or days because they didn't want to believe anything was wrong. They hoped the symptoms would go away on their own. And sometimes the symptoms did diminish because the heart attack ran its course, but by then, significant damage was done. Please don't let that happen to you. I want to end with a few thoughts about listening to your body. We live in a culture that often dismisses subtle signals. We're taught to push through, to ignore discomfort, to not make a fuss. And there's a value to resilience, but there's also a value to awareness. Your body communicates with you constantly. Most of the time, its messages are routine and don't require action. But sometimes, a message is trying to tell you something important. The skill lies in learning to distinguish between the ordinary noise and the genuine signals. With silent heart attacks, the signals are often quiet. They don't demand attention the way a sudden, crushing pain would. They whisper instead of shout. And it's precisely because they're quiet that they can be so dangerous, easy to dismiss, easy to explain away, easy to ignore until it's too late. What I'm asking you to do is to take those quiet signals seriously, not with panic, but with respect. If something feels wrong, investigate. If a symptom persists, seek evaluation. If your body is telling you something, listen. The goal isn't to live in fear of every ache and pain. The goal is to live with awareness, to catch problems early when they're most treatable, and to protect the function and independence that matters so much as we age. Over 30 years of practice, I've learned that the most important thing I can do for my patients isn't always prescribing the right medication or ordering the right test. Sometimes it's simply giving them permission to take their own symptoms seriously, telling them that what they're experiencing matters, that their body's signals are worth investigating. So, if you've been told that your symptoms are just aging or probably stress, and something in you still wonders if there might be more to it, trust that instinct. Ask questions. Seek a second opinion if needed. Advocate for yourself. You know your body better than anyone, and that knowledge matters. Thank you for listening today. If any of this resonated with you, if you've experienced symptoms that were dismissed or overlooked, I'd genuinely like to hear about it in the comments below. Not because I can diagnose you through a video, but because sharing these experiences helps others recognize that they're not alone. Take care of yourselves, take care of each other, and pay attention to those quiet signals. They might be telling you something important.